Thank you for your kind words and for giving me this opportunity to share some of my views. I am very delighted. I see this a very prestigious platform, and Dr. Satpathy has worked very hard over the months. I bring greetings from ILBS, and I would just like to say Dr. Satpathy had given us the privilege of being with him when he was in India, and we were all together. Today, I will be discussing about the management of alcohol associated hepatitis, an area which I think might be of interest to you. I bring greetings from ILBS, which is a dedicated liver university. I have nothing to disclose except to say I keep friends who never get intoxicated with laurels. Uh, Many of these are fellows, faculty who have contributed, and they bring ILBS to a global framework. Thank you all. I will try and briefly discuss with you epidemiology, a case, a severity of assessment, prediction scores, pathogenesis, very briefly, and management. So in India today, alcohol is increasing, the usage has increased, and we are close to what anybody in the West would be 6.2 billion liters by this year end. The Institute for Liver and Biliary Sciences sees about 7,000 patients with cirrhosis a year, about 150,000 new patients of liver disease. This is the early years. Now it has changed more. In my training days, hepatitis B was the commonest cause of cirrhosis. In 2015, at ILBS, 44% were alcohol associated liver disease. I'll keep calling ALD. And now it is about 48%. Alcohol is the number one liver insult during admission. But what happens? So this is a data on about 5,000 patients who were admitted. Patients who have got alcohol associated cirrhosis was non-alcohol associated cirrhosis. You would see that the people who die admission are more compared to any other cause of cirrhosis. You will see that the patients who die in readmission is more than those with any other cause of cirrhosis. Now I'll start with a case. A 30-year male chronic alcohol user, average 120 grams per day and BMI of 37, last intake for 30 days, and he had also taken CAM for last 12 days, a very common presentation after onset of jaundice, which was 30 days ago. He also took the complementary alternative medicine. He lost weight, had low-grade fever, got abdominal distension 20 days after jaundice, but there was no vomiting of blood or melena or decreased urinary output. In the emergency, he had a heart rate of 110, low diastolic pressure, Predictors, hysterexis, bilateral parotid, spider nevi, had a large, tender, smooth liver, sharp margins, and because of moderate ascites, his spleen was plus minus, and by the time he was seen, he was in grade 2. His bilirubin was 24, high INR, AST, ALT, lactate was 2, but create was normal. Here is a patient you would diagnose as severe alcohol-associated hepatitis and maybe ACLF as per our criteria because he has ascites, he has HE, and he has coagulopathy. Whether he has superadded HILI, herbal-induced liver injury remains a question. As we generally do liver biopsy in almost all, transjugular biopsy in all our patients, we would proceed with that to confirm the diagnosis. And this is what we did on day 3 once his HE was better and SIRS was better. So the liver pressure, HPPG, was 17. The biopsy showed macrovesicular steatosis, as you will see, Mallory Dank bodies, There was also mixed inflammation, lymphomolecular cells, and ductular reaction. And his score, AHHS score, alcohol hepatitis score was 8 by 9 as per NIH. So here is a patient who has classical alcohol associated hepatitis. The liver biopsy is suggestive of ongoing injury because of maluried bodies, which in a way are the ones which are neoantigens and continue the immune injury in the liver. I'll now show you another case, which I'm not going to discuss, is a patient who has a MELD of 24, has metabolic syndrome, and what we will call as MET-ALD. Why I'm showing you this is because of this paper which we published several years, 6 years ago. And now this paper describes what India is seeing every day. A positive family history for metabolic traits predisposes to early and more severe alcoholic cirrhosis, a cross-sectional study. This was about 1,000 or 1,100 patients. The patients who had both family and personal history, they themselves were diabetic or mother or father were diabetic, had a 3.3 times higher risk of an early age at diagnosis, maybe 30 to 35. 13 times higher risk of progression to cirrhosis compared to those who did not have metabolic traits with lesser amount of alcohol and 4.6 times lesser duration of alcohol consumption. So, if a person has metabolic traits or there is a family history of metabolic traits, the chances that he will get a severe disease at an earlier age is more common. Let me show you some more recent data in Nature Communications. This is the baseline risk of developing alcoholic cirrhosis or ALD. Now, if this person is having heavy binge, the risk will increase to something like 3.5 times. If he has polygenic risk score, which you know, PNPLA3, or it is uh, BOAT, or it is PCSK, because of these, the risk score, he will now have a risk of 4 times. If he has diabetes, plus he is having drinking, the risk is about 2.5 times. But now, if all of them are put together, you see the risk is almost 7 times more. And this is where most of the India is, or maybe some other parts of the world are facing. The increased risk, PNPLA3 is not uncommon, maybe 20% or so are heterozygous, and about 7 to 10% are homozygous in our population. Diabetes is common, and of course, all these are put together with a habit of heavy drinking. Having learned this, next time you see a patient of metabolic liver disease and alcohol, what they call as MET-ALD, remember that he may have a poor outcome. How do you assess severity and how do you predict what will happen to therapies? Conventionally, a MELD above 20 has been declared to have a mortality of 20%. 1 in 5 will die. In the past, and we even follow today, discriminant function or MDF, Maddrey's discriminant function, is the one which we all consider important. 4.6 into PT difference means, let's say patient has 35 and control has 12, you will subtract and then multiply with 4.6 and add bilirubin. For example, it is a difference in the PT is 6 seconds. 4.6 into 6 seconds, and then you add bilirubin, and that will give you the DF. So there are two ways of looking at it. One is to start a steroid and assess, and one is to stop or continue the steroids. Starting steroids, you generally have a PT, as I told you, which has bilirubin, PT, and INR, and a MELD, which also includes creatinine. But for stopping, you will use normally Lille score, which has bilirubin, PTINR, create, age, albumin, and change in bilirubin from day 0 to day 7. However, none is useful for alcohol and ACLF. Our case was one who had developed ascites and was an HE. None of these scores are good, and I'll show you what is good. We use generally in a patient who has alcohol associated ACLF, means patient has ascites, coagulopathy, and presents as a severe liver disease. This score, ARC score, APSL, ACLF, Research Consortium score, bilirubin, He, INR, lactate, and creatinine. In our patient, bilirubin was high, 22.2, so he got 3. He was in grade 2, gets 2 marks. INR was 2.2, so 2. Lactate was 2, and creatinine was normal. So he totally got a score of 10. So this is now very bedside method of classifying the grade of liver failure in a patient who has cirrhosis. So this is grade 2. He has an ARC score of 10. People who have an ARC score of 10, and I'll show you later, versus those who have an ARC score of 11, they behave differently. Let's briefly touch pathogenesis before we go on to the management. Please keep noting your questions. Please keep firing into the chat box or tell Dr. Satpathy. Now, this is a very standard old diagram to show you alcohol when it comes into the upper bowel will have the gram-negative bacteria which will be released, and the LPS goes to the macrophages. Here you will have, I'll not go into details, but it will be a release of reactive oxygen species. You will have TNF-alpha, interleukin-1, and of course, many other cytokines are released. Then you have in the bowel also gram-negative bacteria here, which will also get released. And the bacteria will also reach into the liver. And in our earlier studies, we have shown in a liver biopsy what are the different types of bacteria are present in this, and you can compare with the gut bacteria. This also gives you an opportunity to learn how you can stop the translocation of bacteria. So if you are giving good amount of fat, generally these are gram-negative bacteria are suppressed, and I'll show you that, and you can convert into lactobacilli, or you can give antibiotics. You can also have gram-negative bacteria coverage by long-term antibiotic therapy or giving lactulose or something. You also can have LPS or TNF-alpha inhibitors, IL-1, or ROS inhibition. There is also a mechanism inside the hepatocyte where there is a increased amount of damage. So the S-adenyl methionine is decreased. There are many other things, but just to say one of the targets could be giving in one way semi. Let's go a little more deeper into this. So this is the injury that you have in the alcohol induced into the hepatocytes. The dams are released. I will come into more importantly about the macrophages, neutrophils, and platelets. And I will be discussing about dysbiosis later. So this is our first study which we showed, and there was a huge debate that neutrophils are beneficial for decreasing the injury in alcoholic liver disease. But we showed that the albumin is changed within no time, maybe in few minutes. And this leads to neutrophils changing. These neutrophils become very active, aggressive, and they cause oxidative stress. So presence of neutrophil in a liver biopsy is not always a good sign. Let's look at what the hyperoxidized albumin does to the platelets to promote inflammation. Remember, platelet count is low in all cirrhosis, but not that much in alcohol patients. Here in severe alcoholic hepatitis, there are good amount of platelet, but your oxidized albumin, which we call as HNA1, that is the non-mercaptan albumin type 1 or type 2. If the type 2 is above 12%, mortality is high. It is easy to do it. But what do these oxidized albumin do? They activate the platelets, and finally, these platelets are pro inflammatory, pro thrombotic, and therefore, remember, avoid giving albumin in these patients. The third part is very important, and this shows you the lipid transport proteins are changed in severe alcoholic hepatitis. Don't go into this complicated diagram. See this severe alcoholic hepatitis, the lipid droplets increase not only in the liver but in circulation. These lipid droplets stimulate macrophages, and PON1, the drugs are getting developed for this, will cause decrease in lipid droplets and macrophage inflammation. So I've shown you some of the work which ILBS has done, and these were all by Dr. Jaswinder from our group. Now, let's go to the main topic of managing severe alcoholic hepatitis. So this is the rationale for treating. What we want is to suppress the injury or inflammation. This we can achieve by some of these methods. We don't want infection because our macrophages, our neutrophils, our innate immune cells are not so active. We have to remove toxins, stimulate liver regeneration. So what is the easiest and everyone's expertise is nutrition. What is the prescription that we generally use? We give nutrition as 35 to 40 kilocalories per kilogram. It comes to about 2,600 to 3,000 calories. This is Mendenhall's landmark work. You might recall all patients with ALD who had received 3,000 calories survived all, and those who received 1,000 calories died. Can't be so simple, but this is the famous paper by Mendenhall 1995 VA cooperative study. But giving good amount of calories is good. 30 to 35% we believe should be fat, and it can be saturated fat or it can be any other variety which you think proper. 1.5 grams proteins, sodium, meals, multiple, and I generally require an NGT feeding in these patients. People do not give intravenous lipids, but we have shown in the earlier papers giving omega 3 as an intravenous lipid is extremely beneficial, and in 3 days' time, a negative nitrogen balance is converted to positive. There is no harm, no risk of giving in a bilirubin of 20 an intravenous 3 omega 3 fatty acid supplement. It gives good calories. And of course, you have to give other multivites and minerals. This is a letter to editor which we showed all our patients at that time. This was the thesis of Dr. Chetan Kalal. Those who had received more than 25 kilocalories had a better survival than those who had, and this is time in months, those who had lower calorie intake. So feed well. This is an important diagram from one of the landmark earlier works uh, by Lieber's group earlier. So it shows you when a patient comes to the ICU, in a very short period, his calorie debt has to be covered. When he comes, he has been taken off alcohol. So his calories which were coming from alcohol has gone away. He is getting all the tests done and he is getting probably very little calorie. So in the beginning, the calorie debt can be as much as 1200 to 1500 calories. And what you need to do is to give this calorie debt has to be reduced. There is something known as a day 9 syndrome. Day 9 syndrome is one where if you have not corrected calorie debt, the patient becomes worse. He came with a bilirubin of 10 and he becomes 14 or 20. This is our mistake. And the mistake is the day 9 syndrome has set in. So remember, calorie debt cover in 3 to 5 days time. Let's go on to our standard. The only possible treatment accepted is corticosteroids to suppress inflammation. The 60 to 70% of the patients will respond modest on short term. The mortality is decreased. The famous Topaz trial showed that the benefit is 0.06. 40 milligram per day of prednisolone and methylpred of 32 milligram. Non-responders have poor outcome. Means those who have not responded, they're gone. This is a very good multi-center trial, a multi-country trial in which Paul Arab showed that who is likely to respond. So what is the therapeutic window? So patients who had a MELD above 20, but they start responding best. Highly effective is this. So highly effective is 25 to 40. Then moderately effective, and then marginally effective. According to their international collaborative study, the patients who were between 25 and 39 responded well. However, it does not include patients who have got ascites or who have got HE. They were the ones which were included. My own feeling, and I would like this to be questioned by you, people who have got high bilirubin or a DF above 6, not really MELD, I would say MELD above 30 or 32 are less likely to respond. So, corticosteroids in which patient and when remains the question. Why? The same study, the same JHEP paper has this very interesting, people have not analyzed, and I'm putting it before you. Now, this is the time in days, and this is the reduction in MELD score, untreated versus steroids. In the beginning, on day 30, those who received steroids were doing better, significant. But by day 90, those who did not receive were doing better. And those at 180 looked like the number was small, was also better. In any way, at day 90 or 180, steroids were not superior. Furthermore, how much is the reduction in bilirubin? Untreated versus steroids. The reduction in bilirubin was just about 1.5 milligram by giving steroids. Hence, if you look at this, a reduction in 1 milligram, or let's say 2 milligram if you take the SD, there would be very little benefit at day 7. And what more can it add? It can add many infections and complications. The problem is everyone is getting steroid and you have to wait day 7 to reduce bilirubin. And 30 to 40% non-responders are also getting it with increased risk and mortality and delay in other treatment. So one of the biggest needs in severe alcoholic hepatitis is a, a prediction of non-response at baseline. Furthermore, if you look at it, those who received prednisolone versus no prednisolone at baseline were same. However, on treatment, no more infection, but post-treatment, the percentage of infections is high. So you've given steroids and the patient is bad. Furthermore, this continues for years. No infection, community acquired, he has gone home and he acquires infection. Hospital acquired, post-hospital acquired. You will see post-hospital acquired infections in those who were treated is 4 times hazard ratio compared to those who never received steroids. Hence, remember, choice to use steroids must be very judicious. So now I'll give you a very master slide. This is based on dozens of studies. What are the predictors of steroids? Before you start steroids, one is a rising number. He came with 10 and 12 and 14 and 18. He will not be a good case. And the bilirubin is already high. In my opinion, high would be somewhere above 15 milligrams per deciliter, or a meld above 30 would be worrisome for me. However, the studies say above 39, but for me, 30. DF above 90, I would say 60 to 70. An ARC score, and I'll show you this, about 10. This is a very important and simple test, urine metabolome, acetyl carnitine of more than 2500. These people will not respond. Transferrin saturation is high, at about 12%. There's another hepatology paper which shows you such patients have more latent iron pool. So the iron has come out of the macrophages and is circulating called LIP. The microparticles ASGPR, acyloglycoprotein receptor, which is a receptor for hepatocyte. The injury is more. If there is more injury, more EVs, extracellular vesicles or microparticles come out. If the quantity is more than 60, then you will say, and this is a simple test of doing EVs. If they are more than 60, the chances are he will not respond. A liver biopsy, which we always do, and I'll show you, is Mallory body and ballooning index. Sorry, if it is more than 6, with presence of cholestasis. Bioenergetics, this is another recent paper which shows that the cortisone, the and mineralocorticoid from adrenals is not getting converted, and the pathway is high 11-deoxycorticosterone has a higher risk of, and plasma urobilinogen sorry, of more than 0.7. Urobilin produced by the gut bacteria from the bilirubin, sorry, bilirubin to stercobilinogen and then urobilinogen for excretion. So if the urobilinogen level is high, it means the bacteria are more active but not good bacteria. This is the acetyl carnitine data. Just see that acetyl L-carnitine above 2500 segregates survivors from non-survivors, responders from non-responders. This is the biopsy which I would like you to pay attention. Here is the ballooning degeneration. You can see hepatocytes, they are ballooned and they are degenerated. You will see cholestasis in the ducts, many ducts. This is the uh, bile duct proliferation with cholestasis, a ductular as well as intrahepatic cholestasis, Mallory Denk bodies, and eosinophilic degeneration. This is the way Dr. Archana from our group had categorized. So if a patient has, this is an MB index, the MB score above 6, you can refer to it, and this is cirrhosis. So we do liver biopsy nearly in all our patients before treating cholestasis, ballooning, Mallory Denk bodies, eosinophilic degeneration, poor survival. He may go straight for maybe consideration for transplant or alternative therapies. But why steroid is not very functional? Why it so happens? This is because the glucocorticoid receptors, the unfolded glucocorticoid receptor actually gets folded. I'll not go into details with this scientific paper. The receptor internalizes and the amount of steroid. Why? Because already the body has produced so much of glucocorticoid, additional steroids do not help. Now, this is the relevance of our patient, the one who had ascites and jaundice, high INR and bilirubin was 22. Here is the relevance. This study done by my colleague Dr. Rakhi from the ARC database of about 5,000, finally 1,200 patients were included. Please pay attention to this. Those who had alcoholic hepatitis and ACLF means they had ascites and they had coagulopathy and had liver failure. the eligibility for steroid was only 30%. Now, those who were eligible, the success rate was only about 44%. To put it in simple terms, only about 12 to 15% patients will be responding to your steroids. 85% will not respond. In other groups, you may have a good response, but in those who have developed ascites, HE, or coagulopathy, the chances are poor. How do you decide at baseline? I don't want to start steroids. I want to be sure my patient is not harmed. Here is the relevance of the ARC score. The ARC score, if it is 10 or less, likely to respond to the steroid. Steroid responsiveness is determined by an ARC score below 10. If the ARC score is above 10, the steroid non-response will come. Also, mortality will be high. So very simple bedside score, bilirubin, INR, lactate, and HE, and add creatinine. Simple before you start. ARC score 11 or 12, don't touch with steroids. This also tells you that if a patient has got a type of ARC grade 2 or 3, our patient with an ARC grade 2, the chances that he will have a steroid response will be about 60%. And if it waits, it becomes 11 or more, then the chances are low. Now you've started steroids. You are a resident or young faculty. The boss comes and says, what have you done to prevent infections? How are you checking up? So this is the gospel. At baseline, before you start, look into the neutrophil lymphocyte ratios, do cultures, including stool culture. GI panel should be sent. A chest X-ray. Also, if the patient can and you can afford, give BAL and all the other tests. At those days, COVID and serum galactomannan, and if possible, BD-glucan and other tests, including MON2, especially for our country where tuberculosis may be latent. And during the 28-day course, if you are giving it, continue these every 2 times per week, and CMV you should do in every 2 weeks, and of course other tests for antifungals. And you may also look into if the HE develops, patient deteriorates, then maybe MRI brain. But why not add antibiotics? They should help. All of us do antibiotics. And this study published in JAMA by Dr. Lovett and Philip Mathurian, what they did was took patients with an MDF equal to or above 32 or a mild and 284 patients. One group got prednisolone plus amoxiclavulinate combination, or the other group got prednisolone placebo 3 times. What they showed, very importantly, the infections were lower in those who received antibiotic, but survival at 2 months, not even 3 months, there was probably no difference, and response to steroids did not change. Therefore, the antibiotic study has shown antibiotics will not. It is the inflammation, liver injury, damps, and others which determine, not merely infection. Infection is a consequence of liver injury. Let's now go, how do you handle and prevent infection and also suppress infection, and also can you stimulate liver regeneration? G-CSF normally is high already in patients with alcohol related liver disease. Body is trying to make it, but it is inadequate for man. Is it good or bad? It's also, let us see. So this was our first study in acute and chronic liver failure, where we could show that G-CSF prevents sepsis and stimulates liver regeneration because it mobilizes CD34 cells from the bone marrow. So 2 things, prevents sepsis, stimulates liver regeneration. And another study which we had done, and on this, Dr. Risha Moru wrote the editorial, that G-CSF does bone marrow, mobilization of CD34, which can differentiate into mature hepatocytes, so liver regeneration, and G-CSF can stimulate hepatic progenitor cells to produce liver regeneration. Let's move further. How does it actually work? G-CSF, this is before, these are intrahepatic lymphocytes on biopsy and the lymphocytes taken out and the other cells. So after G-CSF, the myeloid derived and plasmacytoid derived dendritic cells increase 12-fold. What do the DCs do? They attenuate. Th1 response becomes Th2 and they reduce the interferon gamma production. So in the cells, interferon gamma production is reduced by threefold. So injury is reduced and there is improvement in clinical stores and survival. So GCSF by increasing the DCs can be helpful. What more can GCSF do? So this is a trial which Dr. Shastri had done. It shows that if you are a steroid non-responder and you have no option, we randomized these patients into two groups. One group got GCSF, other group got placebo. Those who received GCSF after steroid failure did better. Why? They didn't have that many infective episodes. Let's move to the new data. If the GCSF prevents infection and stimulates regeneration, why not combine from day zero rather than wait when they fail? And this is the trial we just got published few weeks ago. GPRED trial. This was done by Dr. Ajay Mishra, one of our. What we did was took people in prednisolone. GPRED means at the beginning GCSF and prednisolone or GCSF alone. And what you can see is prednisolone gave in the severe alcohol associated hepatitis 64% survival, GCSF 78%, but the combo gave 88% survival with lower AKI, HE, rehospitalization, or new infections. I think this is a way forward. The way forward is you regenerate liver, decrease the risk of infection or sepsis, and also try and get the benefits of steroids. So give GPRED and GPRED trial. I would like more to be tested, validated, and improved. But are all patients good for GCSF? No. We have to exclude patients who have already got sepsis, which was done in most of the European trials. If the hemoglobin is low or ferritin is high, it means HLH. If the create is high, this is not a good patient. A patient with sarcopenia is not a good patient. In fact, most patients who will respond are with less than 20 MELD. So here will be a challenge. What should we do if the MELD is high? Be very careful, lower dose. Instead of 300 microgram, maybe 100 or 150 microgram. Don't give every day. Give maybe once in 3 days, maybe once in 5 days or so. If you have carefully selected and titrated your patient, there is a potential of G-CSF to be helpful. Let's move further. Other modalities, FMT, which can be helpful in regeneration, preventing infection, suppressing inflammation. What does alcohol do on the gut microbiota? There are two ways. One is direct alcohol with no liver disease. One is a cirrhosis and alcohol effect. Pure alcohol by itself increases, no liver disease, endotoxins, beta glucan, and it decreases good bacteria, Akkermansia bacteroides and Clostridiales, and it increases the Enterobacteriaceae group. Now, cirrhosis alone, not alcohol, also causes so many LPS, TNF, endotoxins, and decreases good bacteria. Now the problem is the two together. In Hindi में कहते हैं करेला और नीम चढ़ा. You know, taking coal to Manchester. Is that kind of a thing. Now, here you have severe alcohol hepatitis. There is a pathobiont, a metabolome of SAH, and we are describing these papers are under review. So, a person who has cirrhosis, a person who is drinking, has the worst bacterial population in the gut. Uh, Dr. Bajaj and group described the cirrhosis dysbiosis ratio. Normal, good should be more than 2. What is good? Lecnospiracy, ruminococcacea, and Clostridium 40. If you have these three, 2 times more than the bad, Enterobacteriaceae and Bacteroideaceae, you are good. In cirrhosis, it is decreased. In decompensation, further. And if the patient is admitted, it is 0.3. So, what is our aim? Try to bring it to normal. How do you do that? You can do modulation of gut microbiota by diet. You can also do by probiotics, prebiotics. I'll not have time for this, or FMT. Targeted approaches have not been successful. But what in diet? Of course, two things I will stress. One is apple, and the second is saturated fat. The story of apple starts from a very interesting paper in JHEP. Two types of patients or subjects are there. One who drink alcohol and their bacteria are sensitive and therefore they get injury. These are maybe 10 out of 100. 100 people drink alcohol, only 10 get injury. So these are the ones. Now 90% of the people may have resistant bacteria. They drink alcohol for quite some time but still have a healthy liver. But now the question is, this is the guy who has come to us, who has already injury. Now, if he continues to drink alcohol, he is doomed. But can you change this bacteria? And this paper done in animals, mice, showed apple or pectin can change the sensitive bacteria to bacteria. That doesn't mean you tell your next day friend, tomorrow, yeah, you drink and have apple. No way. Saturated fats. Now, ethanol causes two things. It decreases the ability to synthesize dysbiosis. Ethanol causes dysbiosis and the ability to synthesize saturated fatty acids, which is a nutrient to the lactobacilli. So ethanol causes dysbiosis, I showed you, and ethanol can also decrease the capacity to have good lactobacilli. Now you give saturated fat, which is in our term is saturated butter or ghee. It changes the bacteria to eubiosis. How? It actually increases the lactobacilli and which is a nutrient by about 20 times more. It decreases the leakiness and decreases endotoxemia. Let me show you something more. And this is the thesis work of Harshita, who showed very interesting data. In patients with severe alcoholic hepatitis, acetaldehyde, and it causes inflammation, oxidative stress, adiponectin are low. Now there is dysbiosis, endotoxemia. What does fat do? Malnutrition is covered, adiponectin levels are increased. This has all been shown, and this was a oral at AASLD. The dysbiosis is changed in our favor. Permeability of the gut is decreased. Synthesis of the FAB-F and FAB-G bacterial genes are increased. In nutshell, the saturated fat, the change in diet can help. More diet, more is required. Dietary intake of saturated fatty acid or desi ghee, what we say, may lead to eubiosis and improve the disease outcome. Let's go to see why this Slovakian soldier in this pit is still smiling. There is a reason for him to smile because FMT is helpful. Steroid ineligible. We did this study but never published. FMT versus pentoxifylline and FMT versus steroid, which we published, and FMT versus standard medical therapy. This is the first paper when we were lucky to have Dr. Abbe Philip with us, and Abbe designed and worked. And the initial study was on patients, 8 patients, pilot study, compared them with the control, historic controls, and it showed a good survival. But it could be beginner's luck. I'm not going into details what changed. But that allowed us to set up an FMT unit. FMT unit, the processes are very clearly laid out here. Then Dr. Apurva Pandey helped us to carry out this very difficult study. 60 patients on prednisolone and 60 patients on FMT. And they were followed up, as you will see, very carefully. And FMT, compared to steroids, had a beneficial advantage. And this benefit continued for 90 days and neutralized only at 6 months' time. So what I want to say that now there is an alternative to steroid therapy, good, effective. This is a meta-analysis just published, but I must say all these studies were basically Indian. This study is from SGPGI, Lucknow, and there is another study which I think is from PGI, Chandigarh. These show that at 1 month, the survival in FMT is better than standard of care, and at 3 months, it is still better. That is, 90 days is better. But let's not believe in beginner's luck. More data is required. But what does FMT do? This is a very interesting graph, and I want you to pay attention. Here is day 0, and you have done FMT. Now the bacteria take about 7 days time. I can't go into all details. The number of good bacteria or so increases, but they come down. They start again by day 28. Now here is the day when colonization occurs. No, and then they start populating. So day 28 is the day of establishment of the bacteria. Bacteria come, some of them are washed, some are killed by their neighbors, but those who are established, and we were able to very carefully screen whether we go back to the normal. What do these bacteria do? These ZO1 and Claudin, both expressions are improved. This clearly shows that post FMT, the leakiness of the gut decreases. So fecal microbiota transplantation helps in establishing bacteria. The mate cells, this paper is under review. Mucosa associated invariant T cells, they augment the functions, and the intestinal bacterial function improve, but it takes a month. So you want sudden FMT response, it is less likely to come. The ongoing work at ILBS, and this has a very interesting, this is a model which Dr. Shwetang and his students have produced. This model has ethanol plus thiacetamide, which mimics actually any amount of alcohol. It does not produce alcoholic hepatitis and cirrhosis. So you have to give thiacetamide, and then it mimics like a human disease. So opportunistic infections increase, and the short chain fatty acid producing bacteria, they all decrease. But this study shows very interesting. One you give FMT, or other you give cell-free fecal transplant. Remove all the bacteria, just the supernatural. CFT is more acceptable. You will not say, oh, I'm eating shit. So CFT can be helpful, and it has been found to be as effective as otherwise. Let's go to the last probably 2 things. One is anakinra, very much hyped. You suppress inflammation. Remember, IL-1 was one of the major players in causing liver injury. This paper led by Dr. Zabo, Gyeonggi Zabo, one of the most important alcohol investigators, and the trial was called DASH Consortium. So they used three triple edge. One is that they wanted to decrease the permeability by giving zinc, the bowel permeability. They wanted to decrease the damage in the liver by giving pentoxy. And thirdly, release of cytokines, IL-1 especially, receptor, and the antagonist for that, anakinra, was given. So this triple drug combination was compared with methylpred, and 6 months mortality was seen. And this was probably not significantly different, but the trend was that the mortality, the survival was better in the patients who received this combination. However, a recent paper in JHEP, where 147 patients were included, prednisolone was superior to the anakinra plus zinc. They didn't use pentoxy, and this was significantly better. However, here the prednisolone response is tremendously good compared to what we normally would see, 80% or 85%, but here it was exceptionally good. I would not totally eliminate anakinra because it has a scientific basis. More trials are required. Now we have exhausted. We have many more emerging therapies I am not discussing. I'll only discuss plasma exchange. Plasma exchange is required for removing the toxins, for improving the regeneration by removal of toxins, and also INRs and others are high, so homeostasis can be done. So there are several trials on this. I don't have the time, but to show an innovative trial from CMC Vellore by Professor Rappen and the group. What they did was in ACLF patients, they gave Plex and they compared standard therapy. But this Plex came after they have got patients who are included in the study, and they showed that Plex is possible to improve. And this was a Plex which was done as low dose steroids. So here plasma exchange and steroids were combined. Normally, we would be afraid of combining the steroids, but here they combined plasma exchange followed by steroid therapy. Correct me, Dr. Eppen, if I have said something wrong. Liver transplant remains the final, treatment modality with a good survival. This is an old study, but I found it very interesting. What it showed was in a large group of patients, this survival is good. Relapse at least that time, the drinking habits were not so, kind of checked, and majority of them came back. But if you drink after transplant, the cirrhosis development is quite high. In fact, two-thirds develop cirrhosis in just 5 years. They are immune suppressed and they drink, the injury is more. Now, you must have realized what all I have said doesn't change your treatment protocols a lot. Why? Because there is no good experimental model of treating alcoholic liver disease. We have done some very interesting I am not able to show you vegetarian protein diet supplementation and the patient is drinking alcohol. Don't tell others. Reduced AST, ALT, and bilirubin, and TLR4 is decreased, and downstream TNF alpha and IL-1 beta, the anakinra stuff. TGF beta is reduced, and fibrosis goes down, and intestinal barrier improves. So one thing is there, don't keep feeding egg. You just give vegetarian diet and of course fat. Second, vegetarian FMT. FMT means the donor is on the vegetarian diet. These are animals, mice who are on vegetarian diet. They increase lactobacillus. Here you will see maximum Coriobacillaceae and Kurthia, which maintains, these are the species which maintain good health, metabolism, anti-inflammatory. One aspect remains which has generally been forgotten is the AUD, the alcohol use disorder. And I just got this from my colleague, Dr. Mohit, the data for last few months. So Mohit had seen almost 597 ward patients and OPD patients. ILBS is unique. There is a same platform, same floor. There is a de-addiction clinic, and Mohit is a de-addiction expert. He is a DM, de-addiction. and he gives sessions. And this is so beneficial, I can't tell you. What does the AUD clinic provide? It provides pharmacotherapy, counseling, both in motivation and relapse prevention. And now they're undertaking a trial of fecal microbiota transplant to prevent recidivism. And this is the thesis of Srajit. I'll show you just one data. Many of these are no, time doesn't permit. And this was a plenary of, and Mohit presented it in the ASLD, analyzing new onset hepatic decompensation and long-term abstinent craving in patients with ALD. What does it show compared to placebo giving oral naltrexone? So here was the schema. Patients were screened, enrolled, naltrexone versus placebo, 12 weeks into trial. The outcome assessment was seen with or without naltrexone, and counseling was done. So the obsessive compulsive disorder score at 6 months and 12 months was much better, just giving 3 months of naltrexone. The effect lasted for 12 months, and it also prevented liver-related event. The guy hasn't drunk, he doesn't become sick. We need money for alcohol research and industry support. This is probably my last slide to show you what we do, and this has to be further updated. First time the patient comes, we say he's severe alcoholic hepatitis. This is the term is still used, but it should be alcohol associated or related. And we still use DF as our criteria, simple bedside. AUD assessment, the guy is seen by the colleagues. Nutritional therapy is instituted. Dietary modulation is started. And if the patient cannot take nasogastric tube or omega-3 fatty acids and branch chain amino acids, these are all done within first 24 to 48 hours. We identify the golden window, screen for sepsis. If there is sepsis already set in, then antibiotics, antifungals. Is steroid eligible? He goes on to steroids. Kindra, but we give steroids and assess at day 4 and day 7 for Lille score. If there is no response, then patient is in the category of other therapies, or he is steroid ineligible. If he is steroid ineligible from beginning, he is offered a transplant if there is a donor. If he is not, he can have any of these 3 therapies. He can go on to FMT, and we tell him shit therapy is palatable, it might benefit. Or he may go on to G-CSF, which is not so common because these are very sick patients, and about 20 mild, it is not so often. Or we have used in 10 patients MSC, mesenchymal stem cell therapy. We have shown if you give MSCs, umbilical cord MSCs, there is a mitochondrial shift from the macrophages, which are depleted in energy. The mitochondria from the umbilical cord cells are shifted to mitochondria and regenerate your mitochondria. Of course, liver transplant remains an option. We are still following the protocol of 1 month of abstinence or so. This, Dr. Satpathy, is my submission, and only that we need global efforts, collective efforts for together. I do hope some of my messages will stimulate research, raise more questions, and if possible, international uh, collaboration. Thank you for your kind attention.